Good morning, everybody, and thank you for making the time to join us. I thought that I would share a few pictures with you this morning to take you a little bit on a 10-minute journey of what the last few years of my life have been. I think, like many of you, I come to this with how I've grown up and within a particular context. And having grown up in Canada in a multicultural family and environment, I certainly have appreciated the way in which our differences matter and show up, and also the way in which, as a Canadian, I expect to be treated equitably, regardless of how I look like, how I pray, how I believe. And that sense of equity has been something that has probably been a thread throughout the work that I do. And so I was very fortunate. These are pictures from Kenya. As a grad student, I was very interested in looking at the connections between medicine and medical practices, women's bodies, as well as social norms. And so my first thesis looked at how the practice of female circumcision was being carried out within hospital settings within Kenya. And in the process of going to Kenya, and this was all done, through a mentor, in graduate school, I developed a relationship with a hospital there, which is a hospital that had been providing that kind of practice, and is also the largest teaching hospital in Western Kenya. And I was fortunate then 10 years later to be able to return, but this time, instead of being a graduate student, I was a qualified anthropologist, as well as an obstetrician gynecologist. And once again, in that role, I was able to see really firsthand just how social norms play out, and especially how they play out in terms of women's roles and their trajectories in life. And especially being a provider that sees people at the beginning of life as an obstetrician, it's very clear just how much we are born into our conditions of life, and very often born into uneven conditions of life that follow us. I was very fortunate, as I said, to work at Mother Baby Hospital, which is part of Moy University and is part of this collaboration called AMPATH, the academic model providing access to healthcare. And it was through my affiliation with the University of Toronto that I then went to work and was mostly based there for about 8 years, from 2010 to 2018. And our collaboration was one where there was university partners in different countries, with the public healthcare system in Kenya, as well as the academic health institutions within Kenya itself. And this model has now been replicated outside of Kenya to Ghana, to Nepal, and to a university in Mexico. And I think in that role, we're able to see very clearly, especially when it comes to women's health, just how fragile the health system actually is in accompanying people, especially through their health and reproductive health journeys. And at the same time, being there, it was not surprising to see just how stretched the health system actually is. And so one of the things that I have always taken to understand is, never assuming that I know other people's realities. And Lee Miracle, who's a storyteller here in Canada, one of her books has this line about, where do you begin telling someone their world is not the only one? And I've thought that often in my encounters, whether as a researcher or as a clinician. And there are moments, like, for example, from a few months ago, when I was surprised to see that a patient was on a particular regimen that didn't seem to make much sense. And she explained to me You know, as a welfare recipient, I never feel like I have a right to ask about my care or even expect good care. And these are the things that I find in my day-to-day life continue to provide moments of surprise and an obligation to think about how this might be different. In Kenya, where we worked at this large teaching hospital, we asked ourselves a lot about how things might be different. And in this hospital that had about 1,000 deliveries a month, which is busier than any hospital here in Canada, we also had high rates of maternal and newborn mortality. And we asked ourselves, how might this be different? And what we found was that overwhelmingly people were dying because they were poor, because they didn't have peer support, and they didn't have power. And we called those the 3 Ps. And to that end, we worked with community members to develop this model of care called the Chamas. And it groups 20 to 25 pregnant and breastfeeding women, includes 2 elders. It's led by community health workers. They meet twice a month. And the meetings involve both a kind of health education, coaching, mentorship, similar to what we're doing here today. And then the other half of the meeting is a savings and loans program. And in doing so, which now has spread to 11 sub-counties and a population of about 2 million people in Western Kenya, we see that they work. And many of the things that we were seeing in the hospital in terms of adverse outcomes have started to decrease as people are accessing more care, getting home visits, and becoming immunized. And so even as I'm living here in Vancouver for the last 6 years, this is the stuff that I love. And the challenge is how do you continue to do the stuff that you love when you may not necessarily be in the same place or with the same mentors and the same people. And that is a continuous challenge, but I am constantly reminded that there are ways in which we take our learnings from other places and bring them to new places. And that's my challenge now in being here in Vancouver. And I read this last night in a book about, you know, don't ask yourself what the world needs, but ask what makes you come alive, and then go and do that, because what the world needs is people who come alive. And I found that so inspiring as I was closing my eyes. So I thought I would share that with you guys this morning.